All right, I think we'll go ahead and get started. Good morning, everybody. Thank you for joining us this evening for our second module in the six-part series that we're calling the Business of Medicine. I imagine other people will trickle in over the next few minutes, which is great. Just as a reminder, control the slides here. Give me 1 minute. I apologize. Technical difficulties. All right, there we go. So just as a reminder, we're recording this video. That's for the sole purpose that we can post it online so folks can watch it later if they can't be present with us tonight. And the topic for our session tonight is how healthcare as big business affects physician independence and agency. So real quick agenda for the evening. I'll make a few brief intro comments, much shorter than I did at the start of Module 1. We'll talk a little bit about Reaganomics, which was Ronald Reagan's healthcare policy and antitrust rules. I think I shared with some of you, I was an economics major in college, so economics is a fascinating field of study. It's really just mathematical modeling of human behavior, and finance is often overlaid with that. But we'll talk a little bit about some economic history and how it sort of ties into how healthcare has changed over the last 40 years. We'll talk specifically about consolidation in healthcare and how the industry has changed. We'll talk a bit about what we're calling the great physician migration from independence to employment, and talk about some of the statistics around that, some of the implications of that change over the last few decades. And then I'll spend a little time kind of painting an overview of the current healthcare landscape, which includes massive monopolies, publicly traded companies, venture capital, private equity, and new market entrants. And I'll just try to spend a little time defining different pieces of that so we have a sense of what healthcare looks like. Take-home message there is it's more complex and convoluted than it ever has been in the past. And then we'll end with talking a little bit about what's a doc to do in the context of all that. So how should you be thinking about things, what your options might be. And then as we did with the previous session, we will do a facilitated Q&A. And then we'll split into optional discussion. So we'll split into two groups. I will facilitate one and Jordan will facilitate the other. So just as a reminder, if you weren't able to join us for Module 1, it's posted on the WAFP website, wafp.net / well, you all can see the URL there. So should be able to find that and watch the first module if you weren't able to join us in person. So just as a few reminders, what's the goal of the Business of Medicine series? In 2 words, the goal here is around physician empowerment. I think we talked a little bit about that last time. The idea is with additional knowledge and understanding, our hope is that physicians will feel empowered to regain a sense of autonomy and control, which they can then use to improve patient care and increase professional satisfaction. And I shared a bit last time kind of how this series came to be based on feedback from physicians about frustrations around loss of autonomy, loss of influence, and loss of control. Just as a reminder, WFP Professional Affairs Committee is the committee that is sort of heading this up. So Jordan's on the call. Lynn and Alyssa are WFP staff members that are joining us and helping facilitate this tonight. And then I'll be leading the discussion. Because we were recording this session, we won't stop for questions during the presentation. But if you do have questions, please enter them in the chat. And then at the end, Jordan will facilitate a question and answer period. And if you would like to remain, should say anonymous, then you can send that question directly to Jordan, and the whole group won't be able to see it if that's important to you. So Jordan will respect your anonymity when the questions come up at the end. So as a reminder, conflicts of interest with this whole series, no. Opinions, yes. What is being presented is kind of my perspective on things. And as a reminder, I've been out of residency for 15 years, spent the first 10 years doing full spectrum family medicine with Family Care Network up in Bellingham, Washington, and then have spent the last 5 years as the president and CEO of the company. So it's given me kind of an interesting perspective on how the business of medicine actually operates. Again, as a reminder, some of what's in here is just my opinion and my perspective. So take that for what it is. And then at the last session, we introduced this kind of simplistic model of healthcare in the United States. So talking about the 3 different groups. So in the top left corner, provider organizations. These are the folks that actually provide the medical care. So physician groups, hospitals, so primary care physicians, specialists, outpatient clinics, hospitals, ambulatory surgical centers, these types of things. In the top right is all the insurance companies. We refer to those as payers or payer organizations. So there are the commercial insurance companies, but CMS, which administers Medicare, and then state Medicaid programs are also certainly payers. And then, of course, we have the patients who should always be at the center of everything we do in healthcare, but unfortunately, often are not. So Our focus tonight is around the evolution of really provider and payer organizations, with a heavier focus on provider organizations, and again, how those have evolved over the last four decades. All right, so bear with me, a brief kind of economics lesson. So Ronald Reagan became the president in, I think 1980 was elected, started in 81, but the early 1980s. So many of you on this call maybe weren't born then. I was a very young child at that point. And Ronald Reagan came into the presidency at a very interesting time. The late 70s was difficult economically in the United States. There was what's called stagflation, so high unemployment and high inflation. It's kind of an unusual economic circumstance. So Reagan developed an economic policy with the support of Milton Friedman, who we talked about last time. And there were several kind of key pieces to his economic policy. Tax cuts for large corporations to spur growth. He actually decreased social spending. He has a famous quote: "Government is not the solution to our problem. Government is the problem." And you'll see that from time to time. He dramatically increased military spending, and then he promoted what he called free market capitalism. So he removed oil and gas price controls, reduced restrictions on the financial services industry. If you want to ask why we had a financial crisis in 2008, some people would actually trace it back to the early 1980s and some of the Reaganomics approaches. And interestingly, relaxed enforcement of the Clean Air Act, which is a little bit ironic now with climate change the way that it is. And then probably the most significant thing he did from a healthcare perspective is a dramatic loosening in enforcement of antitrust regulations, which allowed for mergers, acquisitions, and an increase in corporate monopoly. So we'll talk on the next slide just a little bit about kind of antitrust and what it means and how it came to be and why it matters. But again, things changed in the early 1980s after many decades of stability and antitrust enforcement. Reagan basically said, nope, we got to change our approach. We got to loosen our approach there. So you all have probably heard the term antitrust. It dates back hundreds of years. And the idea was that a trust was an organization, company, sometimes an individual or a family that owned a massive portion of any given industry. So it could be housing, could be property, could be a variety of different things. And when they owned this, they started to develop monopoly power, and that was problematic in terms of competition and managing prices and quality and such, as we'll talk about. So antitrust regulation started in the 1980s with something called the Sherman Act. And I'm just going to read these quotes for a couple of these acts because I think they frame what we were trying to prevent before Reagan came into office and how that has changed things in a way that has led to our current state in healthcare, but in society at a large level as well. So the Sherman Act was a comprehensive charter of economic liberty aimed at preserving free and unfettered competition as the rule of trade. The act outlaws monopolization, attempted monopolization, or conspiracy to monopolize. So you can't try to create a monopoly in the United States. In 1914, the Federal Trade Commission Act was created. That actually created the FTC. You're familiar with that. And it banned unfair methods of competition, such as price fixing and other things, and unfair or deceptive acts or practices. And then also in 1914, the Clayton Act was passed, which prohibited mergers and acquisitions where the effect may be to substantially lessen competition or to tend to create a monopoly. So again, it was well understood more than 100 years ago that monopolies are not good for citizens, for consumers and such. So these acts were put in place to reduce the likelihood of that. So again, antitrust regulations exist to limit consolidation of power, which disrupts free market competition and ultimately harms consumers. And so pre-Reagan, mergers, acquisitions, large corporations, very highly scrutinized. Post-Reagan, he sort of gave direction that I only want you to focus on activities that are clearly illegal. And if you look at these three acts, there's a level of subjectivity to all of them. So there was a pretty aggressive stance pre-Reagan, and then post-Reagan, the stance was loosened up quite significantly. So this relaxation of antitrust enforcement paved the way for explosive growth and subsequent consolidation across numerous industries. So again, this goes way beyond healthcare, but I'll give you a couple examples. So, go back 50, 60 years, most communities had a local community grocery store. And now many communities have a Walmart or a Costco. And you all know the story. When Walmart comes to town, they can undercut prices so dramatically that the local stores go out of business, and then eventually Walmart has a monopoly because they are the only option locally. This happened in the hardware market as well. So most communities had a local hardware store. Here in Bellingham, we had a company called Hardware Sales. They are still clinging to existence, but they used to be kind of the primary option in town. And then a few decades back, Lowe's and Home Depot planted massive big box stores here, and it obviously changed the local market pretty significantly. And then we're all familiar in the pharmacy market. You probably all know local pharmacists and local pharmacies that have gone out of business when Walgreens or CVS or Rite Aid or these other larger companies have come into town. Walgreens and CVS, I was looking at some data on this, each have about 10,000 pharmacies in the United States. And that is a mind-boggling number. So they are in every single significant size community across the US. So again, these types of companies would have struggled pre-Ronald Reagan, but again, the laws or the enforcement of those laws changed in such a way that you were able to create these larger organizations that can move into markets, essentially push out the competition, and then create local monopolies. So what are the promises and realities of consolidation? So again, when a market goes from multiple players down to one player, what are the sort of promises and realities around that? So there are always two promises that accompany that. One is lower prices through economies of scale. And you probably all know what economies of scale means, but it's just an economic phrase that means as you grow, you can sort of simplify a lot of the support and management structure. So a great example would be, if a community has two hospitals and they have different ownership structures, you need a CEO for each hospital, and you need a CFO, and you need an HR department, and you know all these folks. And if those two hospitals merge into one, maybe now you only need one CEO and one CFO and such. So in theory, overhead goes down a bit because you have those economies of scale, and that reduction in overhead can be passed down to consumers. In the case of healthcare, consumers are, of course, patients, and that will lower prices overall. So that's always one promise with consolidation. And the other major promise is higher quality. And the statement usually is that this comes through standardization. So, Starbucks would say we can make a better latte because we do it exactly the same across all of our stores, across every community. We have the same beans, they're roasted the same way, yada, yada, yada. Higher quality because everything can be standardized. So interestingly, when the consolidation movement started in healthcare, these were the exact promises that existed. So prices will go down when healthcare organizations consolidate into larger entities, and that's based on economies of scale. And the quality of care and the patient experience, the sort of customer service patient experience will go up as a result of being able to do things consistently across the entire organization. I'm sure you can all guess how that's actually turned out, and I'll share some data about it. So those are the promises. What are the realities with consolidation again across any industry? So consolidation means a loss of competition, and eventually a lack of competition, right? When Walmart comes to town and pushes out all the local grocery stores, that's maybe your only option for groceries. And that is what a monopoly is, when there is no longer competition and no longer a true free market. And so what does that amount to? It's probably not surprising. Do prices go down? No. Prices tend to increase because there's no cheaper alternative, right? If Starbucks is the only place to buy a cup of coffee, Starbucks can charge essentially whatever they want for that cup of coffee. And then similarly on the quality piece, do these monopolies increase quality? Usually what they tend to do is reduce investment in quality, essentially cut overhead, cut costs. So reduce investment in quality and customer service, and they can get away with that because there's no competition for customers. And so if you remember back to module 1, what happens for a company when their prices, thus their revenue goes up, and yet their overhead goes down, their profitability skyrockets. And so that's typically what we see with monopolies across all different industries. So take-home message here is monopolies distort markets because they can to drive profitability. Now, I should put the little caveat that does this happen every time in every market? Not necessarily, but we talked a lot last time about how businesses define success, and in most industries, it's bottom line profitability that defines success. And so companies will use essentially any leverage, any power they have to drive profitability. So those are the promises. You'll always hear lower prices, higher quality. The reality is you'll almost always see higher prices and essentially lower quality when a monopoly does develop. So let's take a look at healthcare, and we're going to kind of talk a little bit about consolidation in healthcare, but let's start with what healthcare sort of looked like before this consolidation movement. So the idea with this is that there truly was a free market, and that controlled cost and incentivized quality. So envision in this sort of dotted diagram here, this is a single market. And a market, to be clear, can be a city, can be a region, can be a county. Seattle is probably a market in and of itself, but let's say you go over to Eastern Washington, maybe all of North Central, Washington is a market to itself. And so within a single market, let's say you have 3 different hospitals. Hospital A is owned by the purple company, Hospital B is owned by the blue company, and Hospital C is owned by the yellow company. And so when you have a market with multiple different options, each of these hospitals are sort of held in check. So if hospital A decides we're going to start increasing the cost of all the work we do, all the procedures and inpatient stays and such, well, what happens from there? Eventually, patients and then referring providers realize, oh my gosh, hospital A is way too expensive. When you need that elective surgery, you should go to hospital B or hospital C. And so as a result of that, revenue for hospital A starts to come down. So none of these entities can start to jack up prices because there's consequences for that, because there is local competition. Similarly, if either of these three hospitals decide we're not going to worry about quality, we're not going to invest in customer service, we're not going to update the facility when it needs to be updated and such, then word will start to spread in the community that let's say hospital C, it no longer cares about quality and provides terrible customer service and a bad patient experience and such. And patients and doctors will start referring patients to the other hospital. So again, that's the whole idea with the free market, is that it sort of corrects itself over time. Similar things, say, with the outpatient clinics that always surround these hospitals. So, in this example, 5 different clinics, 1 through 5, with 5 different ownership groups, exact same story. These clinics are sort of competing for patients, both on cost and on quality. Those are the 2 major metrics. Now, it's worth saying that these clinics need to be like types of clinics, right? So a family medicine clinic isn't really competing with the cardiology clinic, but having multiple family medicine clinics or multiple cardiology groups or what have you creates that natural sense of competition. So the whole idea with a free market, and that's the idea with American capitalism, is it balances itself. Costs are kept in check, quality and investment in quality continues to be supported because competition drives that. So again, competition is the key to a truly free market. So what started happening decades ago in healthcare, we started to see consolidation. And consolidation happened in a bunch of different ways, but it's often talked about in horizontal and vertical consolidation. So what is horizontal consolidation? Horizontal consolidation is this picture. So hospital B decided we're going to buy or acquire hospital A, and we're going to buy or acquire hospital C. And so now every hospital in this single market is a blue hospital. And what does that mean? If these hospitals want to raise their prices, they'll do it all in unison, all 3 of them. And there's not really going to be the same consequences for raising those prices because local patients and local doctors referring patients don't have alternative options, right? That's the whole idea, is there isn't really a free market any longer because there is no competition. So buying other sort of similar entities, that's often referred to as horizontal consolidation. So again, in this market, there's now a hospital monopoly. Similarly, vertical consolidation is exactly what you'd think it might be. Hospital B, or the blue company, let's call it, has bought up now all these individual clinics, and clinics 1 through 5 are all blue clinics. So again, now the clinics aren't competing against one another, nor are the hospitals sort of working with the clinics. I mean, I think you guys know how it often works in communities where hospitals are vying from referrals and directions from primary care clinics and such. But boy, the moment the hospital owns those primary care clinics, guess where all the referrals go? To that ownership hospital. So no longer is there a truly free market. And this is a dangerous state, obviously, for any single market. In this state, the whole healthcare delivery is a monopoly, right? There's one single entity that owns and controls all of it. And I think, any of you guys that work in large organizations probably experience something like this. I know of a somewhat local instance where outpatient clinicians who were part of a large hospital system, when they were working in their Epic and looking for referrals, they could only find referrals within their system. So you couldn't actually refer to doctors outside of the system because they wanted to keep it all in-house, right? They were sort of managing that. So again, consolidation both horizontally and vertically. And so this picture, this would be a large healthcare company, right, can dominate multiple markets. And you see it in all sorts of different ways. And I should be clear that you don't really have to own the entire market. If you own enough of a subset of the market, you can start to drive business and contain business and start to distort things in dangerous ways. So consolidation in healthcare is not just limited to providers, that is clinics and hospitals. And I think you all know that. This is a picture of Kaiser. So this top office building picture is the insurance portion of Kaiser. And then I think, as many of you know, outside of Washington State, down in California, Kaiser owns hospitals and then obviously a large number of outpatient clinics as well. So that's Kaiser, both the insurance piece of it and then the actual provider piece of it. So they're both a payer organization and a provider organization. And then any of you that have been in town for any period of time remember a company called Group Health. which had their own insurance plan. And then Group Health, I don't believe owned any hospitals, but certainly owned a whole bunch of outpatient clinics. And what happened a number of years ago? Kaiser purchased Group Health. And so what does Kaiser look like now? That large red box, right? Kaiser is a much larger entity. Kaiser is actually the largest individual health insurance company by covered lives. So they provide insurance to almost 10 million Americans, I believe. And so they have the insurance piece as well as the hospitals outside of Washington State and outpatient clinics as well. So again, one company controlling a massive, massive chunk of healthcare. Then I'll give you another example, kind of local example. So you're probably all familiar with the Poly Clinic, which was primarily in the Seattle area, and then the Everett Clinic. These two used to be independent multi-specialty groups. And then a number of years ago, Optum purchased them. For those that don't know, Optum is the largest employer of physicians in the United States now. I believe 7% of all physicians in the United States are employed by Optum. So that is over 100,000 physicians. And so you'll still see the Everett Clinic name sometimes and Polyclinic and such, but these are really Optum entities. And interestingly, I don't know if everybody realizes this, but United Healthcare is the sister company of Optum. United Healthcare is the one of the largest insurance companies in the US, I think by covered lives, maybe second or third largest in the United States. And both United Healthcare and Optum are owned by a single company called United Health Group. So that's kind of an interesting setup where you have United Health Group. Revenues last year for United Health Group were, I think, upwards of $400 billion. So they make a little bit of money. And they are one of the largest health insurers. And then they employ more physicians than any other entity in the United States. So again, that is one huge, healthcare conglomerate. And again, this has been sort of consolidation that happens over time, and we're left with these enormous healthcare entities that wield a massive amount of power. So this consolidation movement started many years ago, accompanied by those same promises. Again, lower costs, higher quality. When we consolidate, we can drive down costs and we can drive up quality. So the question, of course, is, well, what has actually happened with consolidation now multiple decades later? So for those who aren't familiar, the Kaiser Family Foundation is an independent kind of research foundation. They are not a part of Kaiser Permanente, and they do a lot of interesting work and write a lot of interesting articles. So this is actually an article called What We Know About Provider Consolidation from the Kaiser Family Foundation in late 2020. And I'm just going to read this paragraph because I think this is pretty insightful. There is now a large body of research showing that healthcare provider consolidations tends to raise prices without clear indications of quality improvements. Even before the pandemic, the US healthcare system was becoming increasingly consolidated. The financial strain of the pandemic could increase the pace of consolidation amongst hospitals and physicians, which threatens to increase healthcare costs and premiums without compelling evidence of commensurate quality improvements. Remedial action from policymakers could come in the form of increasing antitrust enforcement, essentially undoing what Reagan did 40 years ago, including taking steps to address any potential anti-competitive behavior in markets that are already consolidated, or targeted assistance to struggling providers that are trying to remain independent. And it's, again, sad and ironic. This was, again, 3.5 years ago that this was written. We have seen through the pandemic increased consolidation. Obviously, the pandemic put massive pressure on healthcare entities, particularly smaller hospitals and smaller independent provider groups and such. So that consolidation trend just continues to march forward in our state as well as everywhere across the United States. So again, I think that first sentence is pretty powerful. Large body of research showing that healthcare provider consolidation tends to raise prices without any clear indication of quality improvement. So that promise of lower prices, improved quality, what we've seen is the exact opposite of that, higher prices without any clear indication of quality improvement. So that is essentially the story of consolidation and what's happened across multiple industries, but it certainly hit healthcare pretty dramatically over the last 40 years or so. Let's talk a little bit about what we're calling the Great Physician Migration. So the journey from independence to employment. And this is just some historical data that I think is interesting. So I was able to pull some data all the way back to 1988. This data was pulled from JAMA and as well as the AAFP. And the black line shows all physicians, not just family physicians. And the two green dots are just individual data points for family physicians. And so let's just kind of walk through this chart in pieces. So in 1988, only 28% of all physicians are employed. And so, to be clear, the opposite of employment would be ownership, right? You're a co-owner in your practice. So, 1988, roughly 3/4 of physicians were independent, owned their own practice or owned a piece of their practice, and obviously that started to change over time. By 2012, 59% of family physicians were employed. That's the green dot there. And then it was about 50% of all physicians were employed at that point. So again, change occurring. And then if we fast forward to 2022, which was the most recent data that I was able to pull, 73% of family physicians employed, and I think it was 74% of all physicians. So really, it's kind of been this flip over the last, 35 years or so, from about 3/4 of physicians owning their practices to now about 3/4 of physicians being employed. And even more kind of astounding data point, this is from the AAFP itself, 91% of new family physicians, those who are 1 to 7 years post-residency, are in employed positions now. So again, I think it's safe to assume this trend sort of continues to move forward. Now, is employment all bad? It's not, and we'll talk a little bit about that. But again, I think this data is insightful, and it's interesting how it really traces along with that consolidation movement. We've sort of seen the same thing in terms of physician independence to employment. So family physician options, from solo practice to huge organizations. So I often think of different practice types that family physicians can join as kind of falling on this spectrum. And at one end of the spectrum would be a solo practice, and at the other end of the spectrum would be employment within a large healthcare organization. And to be clear, this is these options aren't necessarily linear, and there are certainly offshoots from this and such, but this has been kind of a helpful, instructive model. So what does solo practice mean? This is really the physician as the owner of the business. And so what that translates to is complete autonomy and control over operations, including schedules, clinical care, services provided, and such. You are a solo small business owner. You are making all the decisions about how the business operates. You have complete autonomy and control as a solo practitioner. Obviously, if you end up in a group practice, you still have autonomy and control, although you're working with partners who, in theory, are also co-owners. The potential drawback to this, though, is that you're also fully responsible for the business aspects of the practice, including contract negotiation and HR and payroll laws and accounting and taxes and regulatory requirements, government and insurance requirements and such. The list goes on and on and on about all the peripheral pieces that it takes to legally and effectively run a business. And it's interesting, I saw some data recently on why physicians lose their independence, if they are independent, and the number one reason is an inability to negotiate contracts that have sustainable reimbursement rates. And the second one is all the sort of regulatory administrative requirements that come with operating a business. So again, those are the definite downsides of this model. And then on the opposite end of the spectrum, these large healthcare organizations, physician as employee, right? You are no longer the owner of the company. So often that translates into less, sometimes little influence or control over the operations, including schedules, clinical care, services provided, and such. Now, I should say that varies widely across different organizations. I've never been an employed physician. I've always been on the independent end of things, and I hear from my employed colleagues that they're often told this is how many patients you have to see, this is the number of work reviews you have to generate, these are the things you can do and can't do clinically and such. So again, a much lower level of control. But the potential flip side of that is these physicians essentially have no responsibility for the business aspects of the practice. So they are not negotiating contracts, they're not keeping up on payroll or HR laws, they're not doing accounting and taxes, they're not tracking regulatory requirements and all those sort of peripheral business pieces that can be pretty significant. And so what have we seen over the last 40 years? This sort of simple trend of moving from the left side of this spectrum to the right side, obviously. And so physician feedback from the WAFP indicates that employed physicians feel less autonomy, control, and influence in their work. And that's actually essentially why this whole series began, was a response to that and trying to figure out how might we support those employed physicians. And again, the theory here is if you understand more how healthcare is and how the business of medicine works, that you can be a little more effective in regaining some of that control or influence. So again, this is kind of that practice type spectrum that's maybe a helpful mental model to have and to carry forward. Healthcare is a massive industry that's only expected to grow in the decades ahead. So this is a really interesting chart. So this is spending in the United States in billions of dollars. I think this was from 2022. And I think we all sort of appreciate that the US spends a massive amount of money on military. somewhere in the order of $850 to $900 billion. I think the U.S. spends more than the next 25 countries combined or something on military. It's crazy, huge amount. But then you can see on the right side of this chart how much spending in the United States in healthcare. It just dwarfs military spending. So on an annual basis in the United States, $4.5 trillion are spent on healthcare. And so that is just a mind-bogglingly massive amount of money. I think you all know that we spend more per capita in the United States on healthcare than any other developed nation by quite a long shot. I think it's now up to $13,000 or $14,000 per capita per year in the United States. So multiply that by 335 million people and you end up with $4.5 billion. And so the important thing about that chart is, this chart is when you appreciate the size and the scale of the healthcare industry, to many people, investors, entrepreneurs, established companies, the sheer size of the healthcare industry looks like an opportunity. And basically the thinking here is, wow, there is so much money in healthcare. Can we get our hands on a piece of that money? How might we do that? And so this is a lead into the next slide to talk a little bit about kind of the current healthcare landscape. And again, the take-home message here is this is really more complicated than it has ever been. So I'm going to just walk my way through a bunch of different kind of players in the current healthcare market, just to kind of paint a picture of what this looks like. So massive provider companies. So we talked a little about Optum and Kaiser, but Multicare, Providence, I mean, you pick the name. In my region, Peace Health, Skagit Regional, a bunch of different healthcare provider organizations. There's obviously massive ones. There's also smaller ones. There still are independent practices. Even independent primary care practices exist still. So those are players that we're very familiar with. Massive payer companies. I think we know these. These are the insurance companies. So United Healthcare, Kaiser Permanente, Anthem. I don't think Anthem is in Washington State, as far as I know, but many other states around the U.S. Blue Cross Blue Shield. The list goes on and on here, right? Molina and Premera and Regents and Cigna and Aetna and such, all of these payer companies, which are very, very large companies. I think the market capitalization for a bunch of these companies is well over $100 billion, just a mind-bogglingly large number. Publicly traded companies is an interesting one. So remember, publicly traded means these companies exist on the stock market. So you can actually buy shares as an investor in these companies. So United Healthcare, United Health, which, as we talked about, is United Healthcare and Optum combined. Cigna, CVS, even Molina is a publicly traded company. That is kind of a newer phenomenon of healthcare companies going public. That was not very common a number of decades ago. The interesting thing about a publicly traded healthcare company is publicly traded companies, their first obligation almost always is to their shareholders. That is the folks that own a stake in their company. And their obligation to those shareholders, they often feel, is to create a financial return on the investment, right? You can go on your Fidelity account or any other app, and you can buy shares in United Healthcare or United Health, Cigna, CVS, Molina, and such, and you are expecting a return on that investment. So my personal bias, for what it's worth, is that healthcare companies shouldn't be publicly traded companies, because I think it further distorts that question we talked about last time. How does that company define success? And boy, when you have a number of shareholders that are expecting a level of return and putting pressure through your board on your leadership to make decisions that drive profitability, and yet you're also trying to provide really high quality care, that is a tough thing to juggle. And again, I think we can probably all guess how that balancing act often lands. So again, a very interesting thing that these companies go public. Why do they go public? Kind of an interesting question. Probably to raise more money. So when you start selling shares in your company, more capital, more money comes in, and then you often use that money to continue to grow. So it's kind of a vicious cycle of continued growth for these companies. But again, publicly traded companies didn't exist in healthcare a number of decades ago, but they are more and more common now. Private equity investment. So not sure if you all are familiar with this, but private equity companies, how they operate is they typically buy a controlling interest in other companies. Oftentimes they'll buy the entire company in hopes of increasing that company's value and then selling that company to generate investment returns. And so private equity is usually funded from very wealthy individuals that pool their money and give it to this private equity company. And the private equity company typically says, I can get you better returns on this money than you can get in the stock market. So they will go out and buy companies across a whole multitude of industries. And increasingly, they're investing in healthcare companies, which is really interesting. But the typical private equity story is they will buy either the entire company or a controlling stake in that company. And then they will work usually for somewhere between 3 to 5 years to improve the financial picture of that company, to raise the value of that company so that they can then sell it off and return those profits back to the investors. The problem with that is you increase value in companies by jacking up the revenue and decreasing the expense, right? That makes a company more profitable. So when a private equity firm comes along, they are never investing for the long term. They don't have a horizon that goes beyond 3 to 5 years. So anything that costs money now but will pay off down the road is not really on their radar. And I think you all know healthcare is by nature a long-term game, right? We take care of patients over decades of their life. We don't take care of them for 6 months or a year or what have you. We often provide that care for decades. So having healthcare companies owned by private equity entities that have these short time horizons, and they'll do things like increase costs and put pressure on docs to drive up productivity so that more revenue comes in, and they'll lay off staff and sell off assets like buildings and clinics and such, all in an attempt to improve the financials so that they can extract value when they turn around and sell that company again 2, 3, 4, 5 years down the road. So you'll hear that term, private equity investing. It's really about maximizing financial returns. Again, personal bias. I don't think private equity should be a part of healthcare. It is a sort of a dangerous word in my mind because their interests are not aligned with what's in the best interest of patients. Their sole interest is in maximizing the investment return for those wealthy investors that have put money in. That's private equity. Venture capital investment. Venture capital, you're probably more familiar with this term, but venture capital companies invest typically in startup companies or earlier stage companies in hopes that those companies will make it big. So they will grow and often eventually go public and then generate enormous investment return. So y'all are familiar with Silicon Valley and a bunch of venture capital money there and tech companies and such. More and more venture capital firms are funding healthcare startups. And you'll hear terms like disruption. So we are funding a company that we think will disrupt the healthcare industry and such. That sort of, those types of terms kind of grate on me because healthcare is not technology, right? Healthcare is not, particularly primary care, is not a field where technology is going to come in and radically change everything that we do, right? As family physicians, we build relationships longitudinally with patients, and we leverage those relationships to support health and influence change and try to advocate for what's in the best interest of our patients and hopefully get them on board with those changes, whether it's a medication or getting some exercise or doing your colonoscopy or what have you. That basic doctor-patient relationship and the work we're going to do, that doesn't really need to be disrupted. And there's nothing technology-wise that's going to fix or simplify that. That relationship is what it is. It just needs to be supported in primary care. And so it always kind of irks me when I hear this new healthcare companies coming along and they're going to redo healthcare and make it all better, or redo primary care. And I think, what is happening here? So again, venture capital investment, it's all about financial returns. And you have to remember, healthcare, $4.5 trillion. So if they can shave just a teeny sliver of that, that total spend back to a company, then they are going to, they're going to consider that a huge win. So that's the venture capital piece. And then the final piece is new market entrants. And so these are established companies seeking to enter the healthcare industry. So Amazon, Costco, Walmart, the list goes on, right? So and I think Amazon and Costco are offering telemedicine visits that you can do online with a doctor you've never met before who doesn't know you and doesn't have your list of medications and such. Walmart explored and I think continues to explore in-store kind of urgent care type or primary care type clinics and such. Why are these companies sort of putting a foot into healthcare? It's not because they think they can do it better. It's not because they really want to become healthcare companies. It's simply because there is so much money to be made in healthcare. And one of the challenges for large companies, a company like Amazon, is how does Amazon continue to grow, right? When Amazon is small, if you want to grow 5% per year, maybe that's doable. But when Amazon has a monopoly on online retail, how do they continue to maintain that growth rate? And they do it by stepping out into other industries. And so the executives at Amazon are not stupid, right? They're looking around saying, what are the largest industries that are out there that we can put a foot into to maintain this growth? And healthcare is one of the largest, if not the largest industry in the United States. And so they're saying maybe that's it. Maybe that's an industry to step into. So again, you can probably tell my opinions about these companies that don't do healthcare trying to step into healthcare. But that in a whole is kind of a picture of what the healthcare market looks like. It is way more complicated than ever. And the big concern I have with this, and I think you all experience this, is that this just creates fragmentation, right? So if you have a patient that you've known for years that is going online and seeking care from Amazon and then showing up at Walmart for this thing and doing this here and that there, and some private equity company has come in and trying to attract their business and such, that actually doesn't lead to more streamlined care. It doesn't lead to higher quality care. It doesn't lead to more effective care. And the tricky part is patients don't necessarily know that, right? I mean, we see that as primary care providers, as physicians, we understand the impacts that this has, but patients are often driven by cost and convenience and such. And so again, this sort of fragmentation piece I find really irritating and annoying, because I don't think patients realize it is not in their best interest to seek the lowest cost, most convenient care. But that is the world that we're in as it currently stands. So what's a doc to do? This is my last kind of major slide, and then we'll wrap things up. So it's easy to feel powerless in the current healthcare landscape. Large corporations with lots of money, investment companies, venture capital firms, private equity firms, and such. It's easy to feel like, oh my gosh, this is all overwhelming, and these are huge entities. But I would remind you, and we talked a little bit about this last time, but physicians are the economic engine of healthcare. This means that no healthcare company can run without physicians. And I think that's a really, really powerful statement to keep in mind, right? I mean, how is Amazon providing healthcare where they've had to hire a bunch of docs? And so we as physicians, even though we often feel kind of small and powerless, we are the drivers of the whole sort of healthcare industry, healthcare economics and such. So with that comes a level of power and potentially a level of influence and control. And I mentioned this last time, and we're not going to go into depth here, but we'll do that at a later module. But family physicians in particular are increasingly critical for healthcare companies. And I think we talked briefly last time about a move to value-based care, and finally some recognition that cost needs to be managed in healthcare in the United States. And who's gonna do that? It's family docs, it's primary care providers. And so it's been fascinating to watch how even though family physicians may not generate the type of revenue orthopedic surgeons and other specialists do, family physicians are in very high demand. And a lot of the sort of healthcare deals I am aware of are centered around primary care now. And that wasn't the case a decade or two ago. And so again, family physicians, particularly over the next 5, 10, 15, 20 years, we're going to have a lot of control and a lot of authority if we know how to leverage it and use it appropriately. And then remember that you've got options. So I think there is kind of a fundamental question: what type of practice do you want to be a part of? You want to be a solo practice? That sounds intense, but doable and the right fit for some folks. You want to be a part of a large healthcare organization. You want to be somewhere in between. And again, all sorts of different practice styles. There was a question coming out of the last session around direct primary care. I didn't think we'd have time to get to it tonight, so I didn't include pieces of that. But that's an interesting, hopefully we can incorporate that in a future session, but an interesting kind of new emerging practice style that reduces some of the sort of regulatory insurance burden by simply not working directly with insurance companies. So docs are trying to be creative and trying to be innovative about ways they can continue to provide the type of care that brings them fulfillment and professional satisfaction, but does it in a way where they feel a sense of control and autonomy. And then again, that final question: how will you wield your influence regardless of your practice type? So it doesn't really matter where you fall out on this spectrum. You probably have more authority and more control than you maybe realize. And again, I think it's a question of how you will leverage that. First for the care of our patients, but I think, as we've said with each of these sessions, there's also a piece of professional fulfillment, professional satisfaction that matters as well, right? This career is a marathon, not a sprint, so it has to be sustainable over time, and it has to feed you. It has to create a sense of value and purpose, so that you can continue to do it effectively for decades. So final slide here, summarizing the key points. So business and medicine module number 2. Reaganomics, in particular, the relaxation of antitrust enforcement, paved the way for explosive growth and consolidation across numerous industries, healthcare included. So again, this is the kind of primary driver of much of the massive healthcare companies that we see today. Consolidation often leads to monopoly power, which often translates into higher costs and lower quality, the exact opposite of what's often promised. And it's been interesting just in the last maybe 10 years or so that research has started to emerge, as we quoted from the Kaiser Family Foundation, that this is true in healthcare, just like in other industries. The great physician migration from independence to autonomy has translated to lower physician influence, control, and autonomy, and really mirrored the overall consolidation that has existed in healthcare. So it's not by sort of accident or happenstance. Physicians' move to employment has largely tracked with these larger and larger healthcare organizations. Healthcare is a $4.5 trillion. I intentionally put all those zeros up there so you could appreciate how many zeros that is. $4.5 trillion industry. I might have left out 3 zeros now that I look at that. I think that's 4.5 billion. So should be 3 more zeros at the or no, that is 4.5 billion. So yeah, should be 3 more zeros beyond that. $4.5 trillion industry, and this continues to attract attention from Wall Street, publicly traded healthcare companies, private equity, venture capital, and other industries. Again, technology, retail, and such, as we talked about. So more folks trying to stick their hands in the healthcare pot. And then despite all of this, family physicians should remember that we are the economic engine of healthcare and then have more control than we realize. And as I said, in future sessions here in the Business of Medicine series, we'll dive a little bit deeper into what does that control look like? How do we have that? How might we leverage that to change our personal circumstances? So as a reminder, before we get into the Q&A, Module 3 is around payer-provider payment models, how those have evolved over time, and how that has impacted physician compensation and physician contracts and such. So that session will be Tuesday, May 14th at 6:30 p.m. is probably on everybody's calendar already. So that is the end of my comments. We will move on to a Q&A session. So I'll turn it over to Jordan to facilitate this. Again, if you have questions, throw those into the chat or message Jordan directly. And then I should have said this up front, but no question is off limits. Again, don't worry about being offensive or anything. I mean, anything that we want to put out there is great. I think everybody's here just to learn from one another and to further our knowledge. So Jordan, I'll turn it over to you.
Yeah, we don't have a ton of questions for that. So Ivan and I just even think maybe planning it a little bit different from what we're thinking for here is I'm thinking that we'll do the couple of questions and then I would love to to have some discussion, but I think let's just keep it as one big group with the size that we have. I think that will work just fine. So those are my thoughts. We still have plenty of time. So if you got questions, go ahead and think them, and we'd love to have some discussion. So, but the question, really, the one that's here is: has private equity ever invested in primary care or just highly competitive specialties? And they note that they're only partly kidding. So,
yeah,
some ideas about that.
A good question. Yeah, I know of many examples of private equity investing into specialty groups, multi-specialty groups as well. I'm not sure about directly into primary care. Again, you have to remember these companies are looking at, so the private equity firm is going to look at other companies and say, where do I see the maximum opportunity for return over a very short horizon? That's the key, right? From a business perspective, 2 years, 3 years, 4 years, 5 years, pretty darn short time horizon. So you'd look for a business that is maybe struggling but has pretty large upside, where you could make a few tweaks, you could reduce overhead, sell off some assets, and then jack up revenue pretty significantly in a very short period of time. Primary care, because the nature of the work we do is not $10,000 surgical procedures. It's really sort of nickel and diming each patient, each visit, each kind of office procedure we do and such. Again, primary care is a little less attractive.